Welcome to the Deep Microbiology channel. We're excited to launch our new series, Clinical Microbiology Case Studies. Let's dive into our first case and explore its details together. Stay engaged for insightful discussions and expert analysis. Case 1. A 45-year-old male, initially in good health, awoke with pain in the lateral aspect of his left calf, which he attributed to an ingrown hair. By mid-morning, he expressed a small amount of pus from the area, and over the next 8 hours, he developed cellulitis measuring 5 by 10 centimeters. By the following morning, the cellulitis had spread from just below the knee to above the ankle, and the next day, it had turned into an abscess. Despite normal vital signs, the affected area was red, warm, and tender without fluctuance or lymphadenopathy. A physician gave him an antibiotic shot, ceftriaxone, and oral pills, cephalexin, and referred the patient to surgery. A few days later, the abscess was drained, and the pus sent to the laboratory for culture and sensitivity. But before we proceed to the laboratory results, let's break down this case. The infection began as a simple folliculitis, is a common skin condition that happens when hair follicles become inflamed. It's often caused by an infection with bacteria. As you can see here in this image, a superficial folliculitis involves the upper part of the hair follicle, characterized by inflammation and pus just beneath the epidermis. And deep folliculitis affects the deeper portions of the hair follicle, leads to more extensive inflammation, often involving surrounding tissues, and can result in painful nodules, abscesses, or scarring if untreated. Maybe this bacteria were hanging out on his skin, or came from his nose. As we know, 20% of adults carry Staphylococcus aureus in their noses. Once the bacteria invaded deeper layers of the skin, it spread like wildfire into cellulitis and an abscess. The patient referred to the surgery because antibiotics alone would not be sufficient. Abscess formation results in a loss of blood flow to the center of the infected area. As a result, antibiotic levels in the center of the abscess would be low or, in a large abscess, completely absent, allowing the survival of the infecting organisms present there. Incision and drainage removes a large number of organisms and reduces the infected area, making penetration of much higher levels of antimicrobial agents to the infected tissue and killing of the infecting organism more likely. Laboratory result. Sample: 1 milliliter of pus aspirate for culture and sensitivity. Gram stain. It showed gram-positive cocci. Next, biochemical tests were performed to further identify the bacteria. The catalase test came back positive, indicating the bacteria can break down hydrogen peroxide into water and oxygen, producing bubbles. This suggests the bacteria is likely a Staphylococcus species, but further confirmation is needed. The coagulase test was positive. Coagulase is an enzyme that causes blood plasma to clot, which can be observed as clumping. The DNase test was also positive, meaning the bacteria can break down DNA. Finally, the bacteria grew on mannitol salt agar, fermented mannitol, and produced yellow colonies. This is a typical reaction for Staphylococcus aureus, as it ferments mannitol and turns the agar yellow. The susceptibility test was performed using disc diffusion test for most antibiotics, and an E-test for vancomycin. Why? Because vancomycin minimum inhibitory concentration, which indicate the lowest concentration of an antibiotic that inhibits visible bacterial growth, is a very tricky, and E-test confirmed the vancomycin MIC, ruling out vancomycin intermediate Staphylococcus aureus and vancomycin-resistant Staphylococcus aureus. The interpretation of vancomycin MIC for Staphylococcus aureus as follows. If MIC less than or equal to 2 micrograms per milliliter, indicates that the strain is respond to vancomycin therapy, and if MIC 4 to 8 micrograms per milliliter, indicates reduced susceptibility, These strains are termed vancomycin intermediate Staphylococcus aureus, and treatment options for this strain may require alternative antibiotics or combination therapies. And if MIC greater than or equal to 16 micrograms per milliliter, this indicates high-level resistance to vancomycin. And strains, called vancomycin-resistant Staphylococcus aureus, often require alternative treatments such as linezolid or daptomycin. Here the vancomycin MIC is 2 micrograms per milliliter, indicating that the strain is susceptible to vancomycin. The second antibiotic is cefoxitin, which is not a drug that is used to treat Staphylococcus aureus infections, but we use it as surrogate marker for detection methicillin-resistant Staphylococcus aureus, MRSA. Because it considered a better inducer of MICA gene expression than oxacillin or methicillin, and gives clearer endpoints, and is easier to read than tests with oxacillin. The organism here is resistant to cefoxitin, which indicates that it is MRSA. And if we noticed here, the clindamycin and erythromycin discs are placed closer to each other than the other discs, in order to determine whether there is formation of a D-shaped zone of inhibition around the clindamycin. You can find detailed information about the D-test on our channel, as it has been explained previously. Here the clindamycin disc shows a round zone of inhibition, indicating sensitivity, and the erythromycin disc shows resistance. This means the organism, it does not develop inducible resistance to clindamycin during therapy. This type of resistance pattern is called the macrolide streptogrammin phenotype, which is associated with an active efflux pump mechanism encoded by the MRSA gene. This efflux pump confers resistance to erythromycin, but clindamycin remains effective. The rest of the antibiotics show the following results. Doxycycline is sensitive, indicating the organism is inhibited by this antibiotic. Penicillin G is resistant, suggesting the organism has resistant mechanisms, such as beta-lactamase production. Gentamicin is sensitive, meaning the organism is susceptible to this aminoglycoside. Finally, trimethoprim sulfamethoxazole is sensitive, indicating the organism is susceptible to this combination antibiotic that targets folic acid synthesis in bacteria. Conclusion and final result. The isolated organism is MRSA, and it comes in two types. CMRSA, community-associated, found outside hospitals, causes skin infections, and is often treatable with oral antibiotics. In this case, clindamycin, doxycycline, and trimethoprim sulfamethoxazole. CMRSA is commonly associated with sports activities, and is transmitted either through direct contact, for example, among football players, wrestlers, and fencers, or indirectly via fomites, such as shared towels or contaminated training equipment used by carriers. In contrast, HAMRSA, healthcare-associated, found in hospitals, tougher to treat, often needing intravenous antibiotics like vancomycin. While linezolid is an important second-line drug, due to nephrotoxicity of vancomycin, the drug levels must be monitored to ensure that toxic levels are not accumulating. Based on the provided information, which type of MRSA is likely infecting our patient? Please write your answer in the comment section. Thanks for watching. If you enjoyed the content, don't forget to subscribe to Deep Microbiology channel and turn on notifications to stay updated.